Now, we've already discussed the retinacular structures to some extent, but what we have not really discussed are the flexor retinacular structures, the very tenacious transverse volar ligament, the flexor retinaculum at the wrist, or the digital pulleys within the finger. Both of these structures are very important for creating mechanically effective and powerful finger flexion. The extensor tendons are also modulated by the dorsal retinaculum or the extensor retinaculum at the level of the wrist, preventing these tendons from lifting up away from the wrist and therefore keeping them close to the axis of the joint and driving their power more distally into the fingers. The extensor tendons are modulated at the MP joints by the sagittal band. When the extensor digitorum communis reaches the metacarpal phalangeal joint, the free and untethered excursion of the extensor digitorum communis ends. It is now tethered down. More distally, the dorsal apparatus is held down by the transverse retinacular ligament. This is a slightly oblique group of fibers, just ever so distal to the PIP joint, but the fibers arise from the volar plate and the flexor tendon sheath at the PIP joint. The triangular ligament, as we have discussed, assists in keeping the lateral bands together during finger flexion when there's tension to separate them, as we previously illustrated. The oblique retinacular ligament is somewhat unique. It's been called the link ligament by Haynes because it is envisioned to coordinate motion of the PIP and DIP joint. And indeed, we are unable to move either one of these joints a significant distance without also moving the other joint simultaneously. When finger flexion begins, the DIP joint is the first to flex, creating tension in this oblique structure because flexion here requires a greater length for this group of fibers. That tension is transferred to the volar aspect of the PIP, if you will, to kickstart PIP joint flexion. In other words, the DIP joint can only go so far before tension is created to begin PIP joint flexion. Imagine the opposite of extension. Imagine the finger being flexed, and as the PIP joint is the first joint to extend, that extension creates tension again, but now in the opposite direction, and that is what brings along DIP extension with PIP joint extension. Now there is controversy about this. There is debate as to the extent to which this influence is real. And there's also debate about perhaps the influence doesn't really kick in until there's a significant amount of DIP joint flexion. Here, for example, 45 to 70 degrees. Others say that the ORL is an inconsistent structure and we don't really find it fully developed in the majority of individuals. To me, the singular most important thing about the oblique retinacular ligament is to appreciate its potential negative contribution in the presence of other pathology or its own pathology. Because pathology and inability for this group of fibers to move normally can limit IP joint motion, specifically DIP joint motion. We look at the normal tension of the oblique retinacular ligament by maintaining full extension of the PIP joint while simultaneously flexing the DIP joint. This is what takes the oblique structure to its maximum length. If these fibers have adaptively shortened or they are adherent, then it is very difficult for the patient to initiate DIP joint flexion as part of normal finger flexion. It's not uncommon to see a patient following a distal radius fracture who has lost the ability to initiate finger flexion at the DIP joints. To me, this is very logical because the flexor digitorum profundus tendons, being the deepest at the wrist and therefore the closest to the fracture site, more easily become adherent. But secondary to that, the oblique retinacular ligament adaptively shortens because this motion does not occur. And then it's very important for the patient to relearn DIP active flexion initiation as part of finger flexion. What may be helpful is to actually begin with passive stretching in this posture to first remediate the adaptive shortening or adherence of the oblique retinacular ligament so that active DIP flexion initiation is easier and thus possible. The transverse retinacular ligament, we have already talked about how it encircles the entire dorsal apparatus, and if there's PIP joint hyperextension, such as in a swan neck, the constant hyperextension of the PIP joint will cause the lateral bands to move dorsally, and the transverse retinacular ligament can also adaptively elongate, therefore not being effective in limiting the lateral band movement dorsally. It does prevent excessive movement of the lateral bands, except in the circumstance of long-standing PIP joint hyperextension. Here is the same cross-section we viewed earlier of normal extension with the lateral bands somewhat lateral but also dorsal. And when there's hyperextension, the lateral bands move more central and more dorsal, and indeed the transverse retinacular ligament must elongate to allow that. It doesn't elongate from a literal view of stretching. It elongates because the fibers adapt to this constant tension, and they literally grow or change over time to adaptively lengthen. The triangular ligament during finger flexion is what keeps the lateral bands together in the most distal aspect of the dorsal apparatus. Again, when there is a constant force against the triangular ligament, they will adaptively change. We see this in a boutonniere injury, where the lateral bands drop below the axis and stay there at the PIP joint, constantly pulling at the DIP joint. These lateral bands are held together by the triangular ligament. If there was a hole here, which is indeed the boutonniere injury, and these lateral bands drop volarly, that volar motion would provide tension to the triangular ligament, and over time it would adaptively lengthen, allowing those lateral bands to stay in a more volar posture. The same schematic drawing we've looked at of normal extension, and now let's compare this to the pathology of the lateral bands moving too far volarly. For this to happen, you can see that the triangular ligament must elongate in order to allow this motion to occur. A boutonniere injury is an even more dramatic presentation because the triangular ligament may actually be ruptured over time. It may lose its continuity, and that allows the lateral bands to move even further volarly.